Welcome to the Deep Dive. Today we are launching into a really comprehensive analysis of primary aldosteronism, or PA.
Yeah.
And for far too long, this condition has been kind of a footnote when we talk about high blood pressure. But the sources we've been looking at argue pretty persuasively, I think, that PA is one of the most critical and maybe most importantly, most treatable forms of hypertension that you will ever encounter.
That is absolutely right. I mean, if you just step back for a second and look at the clinical implications, it's a bombshell, really.
Bombshell.
Yeah. PA may actually be the single most treatable risk factor for cardiovascular disease.
Yeah.
Besides, the one we all know about, smoking cessation.
Wow.
When you put it like that, the need for an early and accurate diagnosis, it just becomes urgent.
It's strange, though, because historically, PA was just seen as rare. I mean, the old textbooks, they claimed a prevalence of under 1%.
Right.
But our sources are pretty clear that millions of people worldwide are likely walking around with this completely undiagnosed, just at masking as your standard essential hypertension.
Precisely. And that's our mission today. We want to equip you, whether you're a medical student just laying the groundwork, or a professional needing a deep, updated refresher with the whole picture, the translational picture.
So we're talking the new epidemiology, the diagnostic hurdles, the molecular drivers.
All of it. And most importantly, how all that knowledge leads to, dramatically better outcomes for patients.
Okay, so let's start with that historical misstep. Why did that old view, that it was rare, why did that persist for so long?
Well, the sources point to one main thing. For nearly 2 decades, clinicians were basically told only to screen for PA if the patient had hypokalemia.
Low potassium.
Low potassium.
And
that one criterion, it created a massive blind spot.
because most patients don't have it.
The majority of PA patients are normokalemic. Their potassium is normal. So by relying on that, we were only finding the most severe late-stage cases. It wasn't until the widespread introduction of the Aldosterone-Renin Ratio, or ARR, as a screening tool that we finally saw the true scale of the problem.
And that true scale is what exactly? What are the modern figures?
They're staggering, really. After we started using ARR screening, the numbers confirmed PA is found in something like 5 to 15% of all patients with hypertension.
All patients.
All patients. And if you narrow that down and look specifically at resistant hypertension, the patients whose blood pressure is really hard to control.
Yeah, even with multiple meds.
Exactly. That prevalence jumps to around 20%. This isn't a niche disease. It's highly common.
What I find fascinating is how the sources describe this as more of a continuum. It's not a hard on or off switch.
It is a spectrum, absolutely. PA extends right into this entity we call low renin essential hypertension, LREH. And LREH can often just be a mild or sort of subclinical form of early PA.
And the danger is that even in those mild forms, that autonomous aldosterone excess is just causing damage.
Significant unnecessary organ damage.
Yeah.
To the heart, the vessels, the kidneys. And that damage translates directly into an increased risk for cardiovascular events, even when you compare them to patients with the same blood pressure numbers from essential hypertension.
So that's the real clinical urgency, isn't it?
It is. And that urgency leads us right to the next crucial distinction. We have to figure out if the PA is surgically curable. Or not.
Okay, let's clarify those categories because that really guides the whole treatment plan.
Absolutely. So the surgically curable forms, they include things like an aldosterone-producing adenoma, an APA, or primary unilateral adrenal hyperplasia. It's a single lateralized source that we can, just take out.
And the non-curable?
That's usually bilateral adrenal hyperplasia, BAH, where both adrenals are overactive. Or, much more rarely, some of the inherited types, like familial type hyperaldosteronism.
So that distinction means the screening. That initial ARR, it's just the starting pistol. It kicks off this complex race to really subtype the disease.
Right, and that race often begins, and frankly gets bogged down, with the ARR itself.
It's the method of choice, though.
It is, because it identifies the hallmark of PA, which is hyperaldosteronism that's acting on its own. It's autonomous, totally independent of the renin-angiotensin system. We're looking for high aldosterone with suppressed renin.
But just relying on that ratio, that's risky. I mean, the denominator, the renin, can be so suppressed it artificially inflates the number.
That is the key nuance.
Yeah.
A high ARR only really suggests PA if the plasma aldosterone concentration, the PA, is also elevated.
Okay.
So typically above 15 nanograms per deciliter. If your piece is low, say 4, but your renin is basically 0, the ratio might look really high, but you haven't actually confirmed true aldosterone excess.
And now we get into what the sources call the clinical headache. The prep for an accurate ARR, the list of things that can mess it up it's exhaustive.
It creates chaos in the clinic. I mean, first you have the medications. Beta blockers, NSAIDs, they all suppress renin.
Pushing you toward a false positive.
Exactly. But then you have common antihypertensives, diuretics, ACE inhibitors, ARBs, that do the opposite. They can raise renin or lower aldosterone and give you a false negative. So to get a clean reading, patients often have to come off critical medications for weeks. It's a huge management challenge.
And it's not just drugs, it's physiological factors. Posture, time of day, age, even the menstrual cycle.
Oh, yeah. Think about the time of day. An ARR measured mid-morning just from a seated patient is naturally going to be higher because of the circadian rhythm of ACTH. Posture's critical to standing stimulates renin. You have to control all these things.
There's a really technical point in the sources about women on estrogen-containing oral contraceptives, OCPs, that I think we need to break down.
Yeah.
It's about how you measure renin.
This is a perfect example of why the lab methodology is so important. OCPs make the liver produce more angiotensinogen.
Which is the substrate that renin acts on.
Exactly. So if your lab uses a direct renin concentration, or DRC, which just measures the amount of renin enzyme, that ratio can get thrown off and give you a false positive.
Because the extra substrate suppresses the active renin level.
Right. But if you measure plasma renin activity, or PRA, which measures the rate of angiotensin generation, that activity tends to stay stable. So you have to know what your lab is doing, DRC or PRA, if you're screening a patient on OCPs.
Okay, so with all these potential false positives and negatives, a single high ARR just can't stand on its own. We need to confirm that the aldosterone secretion is truly autonomous.
And that's where the suppression tests come in. The saline infusion test, SIT, is probably the most widely used.
How does that confirm autonomy?
Well, we use acute volume expansion. We infuse 2 liters of saline over 4 hours. That massive volume load should suppress aldosterone in a normal person.
But in PA, it doesn't.
It fails to suppress. If the aldosterone concentration doesn't fall below a certain cutoff, say 50 nanograms per liter, it confirms the adrenal is just pumping out aldosterone regardless of what's happening. It's independent.
And there's the fludrocortisone suppression test, the FST, which sounds even more aggressive.
The FST is a 4-day test. You're giving oral fludrocortisone, which is a mineralocorticoid, plus a high-salt diet. You're just flooding the body, maximally suppressing that feedback loop. PA is only excluded if the aldosterone levels drop to almost nothing.
So once PA is confirmed, the next big challenge is subtyping. Is it unilateral or bilateral? And that's where we start with imaging, right? CT or MRI?
We start there, yes.
Yeah.
But the sources are, well, they're harsh on CT's utility here.
Yeah.
And they should be.
Why?
Imaging is just inadequate for reliably discriminating between a functional APA and idiopathic hyperaldosteronism. The sources say that CT results are confounding in about half of all patients.
Half. That's terrible odds when you're thinking about a major surgery.
It is. I mean, a nodule you see on a CT might just be a hormonally inactive insulinoma, or it could be a focus of bilateral hyperplasia. And that confusion leads to inappropriate surgery for some patients. And, just as bad, it excludes other patients from a potential cure because their small functional adenoma was just dismissed.
Which brings us to the gold standard, the test that separates the curable from the controllable. Adrenal venous sampling? AVS.
AVS is still the cornerstone for confirming unilateral aldosterone production. If you're even considering an adrenalectomy, you have to do an AVS first. The problem is it's a very technical, very demanding procedure.
And how do the interventional radiologists even know they're in the right spot, that they're sampling from the adrenal vein?
They use cortisol. Cortisol concentration should be way higher in the adrenal vein blood because that's where it's made. So measuring cortisol confirms that the catheter is selectively placed and lets you correct the aldosterone measurement for any dilution. If you don't get that confirmation, you could operate on the wrong side.
The difficulty of AVS is why the promise of new imaging techniques is so exciting. Tell us about these PET tracers.
Yeah, this is a huge step forward. The development of PET using tracers like carbon-11 metomidate is a game changer. Metomidate binds specifically to the enzyme aldosterone synthase.
So if an adenoma is making aldosterone, it lights right up.
Precisely. It lets us distinguish an active aldosterone-producing adenoma from just a silent nodule. And if you pre-medicate the patient with dexamethasone, that quiets down the background noise from the normal adrenal tissue, making the active adenoma stand out even more. This could one day make the technically challenging AVS obsolete.
Let's shift down to the cellular level. What's driving this? What actually makes the cell produce aldosterone? And how do these mutations hijack that system?
So aldosterone is made in the zona glomerulosa cells, and normal production relies on maintaining the right cell membrane potential. It's mostly governed by potassium channels and angiotensin II signaling, which controls calcium influx. When the cell depolarizes, calcium rushes in, and that's the signal to make and release aldosterone.
And the big breakthrough for understanding sporadic PA was the discovery of these somatic mutations in a gene called KCNJ5.
A profound discovery. KCNJ5 codes for the GILK4 potassium channel, which is crucial for that resting membrane potential. In sporadic PA, we find these gain-of-function mutations in the channel.
So what does that mean, gain of function?
Think of the channel as a finely tuned gate. It's supposed to let potassium out but keep sodium out. The mutation basically breaks the filter on that gate.
Like a faulty lock.
Exactly. It disrupts the ion's selectivity. So now sodium ions can just rush into the cell. This influx of positive charge causes chronic membrane depolarization. The cell basically thinks it's being stimulated 24/7, leading to nonstop aldosterone secretion and cell proliferation.
And beyond these sporadic cases, we have the inherited forms, the familial hyperaldosteronism phenotypes. Let's start with FHI, the glucocorticoid remediable one.
FHI is caused by a chimeric gene. Parts of two other genes get smashed together. And the result is that aldosterone synthesis gets put under the control of ACTH, the hormone that usually controls cortisol.
Which is why dexamethasone works. It suppresses ACTH.
Right. The high blood pressure and aldosterone just normalize with dexamethasone. These patients also produce these unique hybrid steroids, and they face a really high risk of early stroke.
And what about the more severe one, FH-3? That's linked back to those same KCNJ5 mutations, but germline.
Right. Inherited. FH-ADU is highly variable. It often shows up in childhood with just severe resistant PA. These mutations can drive massive bilateral adrenal hyperplasia, often requiring both adrenals to be removed. And like FHI, they also produce those hybrid steroids, but in the most severe cases, the levels can be even higher than what we see in FHI.
So let's bring it all back to the patient, therapeutic outcomes. For that lateralized unilateral disease, what do the surgical results look like?
Unilateral adrenalectomy is the gold standard for lateralized PA,
Wow.
and the benefits for the patient are massive and they're rapid. Potassium levels normalize in pretty much 100% of patients, and importantly, hypertension is just cured gone in 30 to 60% of patients.
And the rest?
The remainder sees significant improvement in their blood pressure control. They need less medication.
But again, we have to emphasize no surgery without AVS confirmation.
Absolutely essential. And for the bilateral disease where surgery isn't an option, medical treatment is all about mineralocorticoid receptor antagonists, MR antagonists.
Yeah, spironolactone and eflornithine, what guides the choice between them?
Well, spironolactone is very effective, but it can cause sex hormone-related side effects like gynecomastia in men because it also blocks androgen receptors. Eflornithine is more selective, so it has fewer of those side effects, making it a common preference, even though you sometimes need a higher dose.
We talked about cardiovascular risk, but let's circle back to something the sources really stress. Quality of life. Cure well. How does PA actually affect a patient's day-to-day life?
It's a huge deal. PA patients consistently report lower quality of life scores compared to the general population, especially in areas like physical functioning, general health, and just vitality.
And why is that?
It seems to be tied directly to the symptoms of aldosterone excess itself, palpitations, muscle weakness, neuromuscular issues, but it also includes things like anxiety and depression, which might be linked to direct effects of aldosterone on the brain.
So does treatment just fix the numbers, or does it actually fix how the patient feels?
It fixes both. Both surgery and medical treatment improve those QOL scores significantly. But, and this is a crucial distinction, the sources note that surgery for unilateral disease leads to a faster and more complete recovery of quality of life compared to chronic medical treatment for the bilateral cases. If you can cure it, the patient feels better, faster. So the big translational insight here is that PA is a highly prevalent and potentially curable form of hypertension. Our improved understanding from the mutations all the way to the nuances of the ARR is vital, not just to prevent cardiovascular catastrophe, but to markedly improve the patient's daily experience, their vitality.
Okay, let's unpack this one last time. The shift from this rare hypokalemic disorder to a really prevalent condition that needs these meticulous diagnostic protocols controlling meds, confirming with suppression tests, subtyping with demanding things like AVS, it really is one of the great medical stories.
And here's where it gets really interesting for me. It's the molecular discoveries, that simple broken ion channel, KCNJ5, just forcing nonstop secretion. That's what validated the entire search for PA. It cemented its role as a key target for truly personalized therapy.
So to reinforce all this, here is a short exercise for you, the learner. Imagine a patient is taking a common beta blocker for migraine prophylaxis. They undergo PA screening and their ARR comes back elevated, but their plasma aldosterone concentration is only 6 nanograms per deciliter. Discuss the likely effect of that beta blocker on the ARR and explain why this result, despite the high ratio, likely does not confirm primary aldosteronism. We encourage you to review the interaction between renin suppression and PET thresholds.